Good evening, everyone. Welcome to Monday Night Live with BRCA Strong and PRMA Plastic Surgery, our gold sponsor for 2021. Tonight, we are so excited to have Dr. Garza come on and speak about surgical options for lymphedema. So as we just wait for everybody to join us, again, I'm Tracy, the founder of BRCA Strong. Thank you so much for joining us tonight, and we are so excited to have a special guest to talk about lymphedema, as so many women face this and don't know what to do, don't know how to. There's options available. So figuring nothing but better than Dr. Garza to come on and talk about lymphedema and the treatment options. Good evening, Dr. Garza. Welcome on. Thank you so much for
Hi.
joining us.
Yeah, thank you for having me.
Perfect. I was just telling everybody a little bit about what's going to happen tonight and then talking about the topic. So normally what I do is I just introduce myself again. For those of you that don't know me, I'm Tracy, the founder of BRCA Strong, and we are so excited to have Dr. Garza on, who is Dr. C's partner, who is from PRMA Plastic Surgery and who's a gold sponsor for 2021. PRMA has been so supportive in education, in patient advocacy, and everything that they can do, and just making a difference no matter where our patients end up, as long as they're in a safe facility. The app for Breast Advocate, if you guys do not have that app, please make sure you download that as well, as it is such an educational tool to women who are looking for their breast reconstruction options and surgical treatment options for lymphedema. So what I'd like to do is, if you don't mind, Dr. Garza, before we get started, if you just want to do a short introduction.
Yeah, sure. So I'm one of the plastic surgeons at PRMA. We do microsurgery, so I have microsurgery training, and as part of my training, I did some lymphedema surgery, and that's something I've really become passionate about, and learning more about lymphedema and its surgical treatment. So that's what we do at PRMA, breast reconstruction, and then I do the lymphedema stuff. So
Perfect. You know, what's so interesting is over the years, lymphedema's gotten a lot more awareness, right? So
absolutely, yeah.
when I was speaking to Courtney, I'm like, I only knew there was lymphedema sleeves. Like, I didn't really know there were surgical options. So for me tonight, it's going to be an educational experience as well. So I appreciate you taking the time and dedicating, to continue to make a difference in our community, as that's what we're really here for, is just to give women resources at their fingertips to let them know what's available.
Right. And so many, just like you said, a lot of people don't know, and even clinicians. I do a lot of education at conferences and things, and give lectures, and clinicians themselves aren't aware that there's other options aside from compression sleeves. So lymphedema therapists, certified lymphedema therapists are very important in helping manage lymphedema. And sometimes clinicians aren't aware that there are people who have specialized training in treating lymphedema from a therapy standpoint. So that's also some of the education things that we try to do.
Perfect. So, to open up with the first question, I'd like to say, what are the symptoms of lymphedema and who's at risk for developing it?
Yeah, so great questions. So I'll start with the risks. The people who are at most at risk for developing lymphedema are people who have had surgery in their lymph node area. So you have different lymph node basins throughout your body. When treating breast cancer, the lymph node basin that we're particularly talking about is the axillary lymph node basin, or the lymph nodes that are involved in the armpit. So patients who have had 10 or more lymph nodes removed from the armpit area, patients who are going to have radiation, those are like the biggest risk factors for developing lymphedema. So again, lymph nodes removed and then radiation. Other things, chemotherapy, BMI higher than 30, all those risk factors put somebody at higher risk for developing lymphedema. If you've had a sentinel lymph node biopsy, which is usually 1 or 2 lymph nodes, maybe 3 lymph nodes removed from the axillary area, not quite as high a risk. Although if you look at the literature, in some literature reviews and studies, it has shown that even in sentinel lymph node biopsies, some patients can have up to 5 to 10% risk of developing lymphedema. So it can affect a large range of people. And I've had patients who have sentinel lymph nodes removed and they develop lymphedema. And then I've had patients who had a large majority of the lymph nodes removed from their armpit area with an axillary lymph node dissection. So we're talking 20, 30 lymph nodes sometimes, and they don't develop lymphedema. And it's like, well, how does that happen? And it's not something that we very clearly understand. But as far as risk factors, those are the risk factors.
So just out of curiosity, does your BMI really play that big of a role in lymphedema?
It can, because one of the things that happens in lymphedema on a long enough time frame, so there's a couple different staging systems. The one that we typically use is a three-stage system. So stage 0, stage 1, stage 2, stage 3. Once you get to that stage 2, stage 3, there's a lot of fatty deposition, and that changes the architecture of the arm. So you can have fat deposits throughout the extremity, the affected area of lymphedema, and they think that can have some, the BMI can have some influence on that, and the mismanagement of where the adipose cells are being deposited. So that's, when I talk to my patients who have lymphedema and are BMI above 30, I tell them, like, this is the only risk factor you can control. You can't control that you had radiation. You can't control that you had lymph nodes removed. So if you want to kind of try to take control of this thing, the one thing you can control is your BMI and weight loss. And, I've had lots of patients who have BMI less than 30 who have lymphedema. So that's not the end all be all, but that's one factor that you can influence and potentially help the situation from getting worse.
So one of the girls said, I was chosen to be part of a lymphedema study. However, the day my double mastectomy and total axillary lymph node removal surgery, the camera malfunctioned. My surgery was 2017, and luckily, so far, I haven't experienced any lymphedema. So lymphedema can come over time. It's not necessarily done obviously, say we have lymph nodes removed. It can develop over time. It's not something that just happens, correct?
Yeah, correct. That's another interesting thing, the time frame to when it develops. Sometimes it's years, sometimes it's shorter. So within months, it can start having symptoms. So with your first question, you asked what are the typical symptoms people have. It can vary. When you think of lymphedema, obviously the swelling. So the swelling in the affected limb, that's one of the symptoms of lymphedema. But before that, typically patients will complain of like a heaviness in their arm, or a dull ache in their arms, and also a common complaint. Loss of dexterity in the fingers. So they may notice that, hey, it just feels weird when I try to move my hand. It doesn't feel quite the same. Particularly with the swelling, if you wear rings or your watches or bracelets, you may notice that they're fitting a little bit tighter. So it may not overtly look swollen. You say, this hand, my ring isn't fitting quite like it used to. And I've had several patients who comment on that that's one of the first things that they had noticed was that their rings, the dull ache and the rings not fitting quite as well.
Now, does it only happen with patients who have cancer, or can it happen in the patients who take proactive surgical action, and do preventative mastectomies? Does one of the women asked me, can it happen if they were not diagnosed with cancer and just had a preventative mastectomy?
It would be very unusual for that to happen, because the lymph nodes in that, in a purely prophylactic mastectomy, the lymph nodes aren't being removed. So that would be an unusual sequelae of having a prophylactic mastectomy. Is it possible? Yes. And anecdotally, I believe I've heard of that happening, but I have not personally taken care of anyone who has had lymphedema after a prophylactic mastectomy.
Okay, perfect. And what are some of the most common methods of treatment for lymphedema?
So great question. There's two main surgical options. Well, I guess three main surgical options for lymphedema treatment. The two most important ones, I feel, are the ones that are considered physiologic lymphedema surgeries. That's where we try to improve the lymphatic fluid management in the arm. And the other category is physically making the arm smaller by cutting out tissue or doing liposuction. That doesn't do anything to help the mismanagement of fluid. That is what the issue is with lymphedema. So the physiologic approaches that we have, the physiologic surgeries that we have to improve lymphedema are a lymph node transfer, where we take lymph nodes from another part of the body and transfer it into the area that's the affected limb in lymphedema. And then the other option is to do something called lymphaticovenous anastomosis, or LVA. You also hear it called a lymphaticovenous bypass. It's all the same thing, it's just different names. And with that, we reroute the lymphatic channels to a vein. So in lymphedema, the lymph nodes are removed, so you have scar tissue develop in the armpit area. That the lymphatic channel, which would, in a normal, healthy scenario, take the lymphatic fluid to the lymph nodes, get processed, and then ultimately get back into the systemic circulation. That process has been disrupted. So in lymphedema, there's scar tissue here. With LVA, we reroute the lymphatic channel to a vein. So now that lymphatic fluid is transported into a vein for systemic circulation, and it can then be, returned to the heart and leave the extremity. And those are the two physiologic options. The non-physiologic options, again, are liposuction or physically removing the tissue. And again, that doesn't help the fluid mismanagement. So patients will still have to wear a compression sleeve, but it may, reduce the physical size of the arm.
And at PRMA, what do you guys offer patients as their options for surgical options?
Yeah, so we do the lymph node transfer. The way we do our lymph node transfer is in conjunction with the DEEP flap. So an example of a patient scenario that would require something like that: somebody who's had a mastectomy, has been radiated, and after their mastectomy and radiation has gone on to develop lymphedema. Then they would present to us as a delayed reconstruction. So they've had their mastectomy, radiation, have not had any reconstruction, or they've had maybe an implant or something along those lines, and they've developed complications of lymphedema, and they want the breast reconstructed using their own tissue. In that scenario, we can do the breast reconstruction with the tissue and transfer the lymph node at the same time during the same procedure. For patients who have already had a reconstruction or don't want to have a breast reconstruction, and they want to just focus on their lymphedema, you can do an isolated lymph node transfer. It's challenging to do that because the donor sites there's not a great donor site. There's not a perfect donor site, I should say. Each time we transfer lymph nodes, there's always a risk of developing lymphedema at the donor site. So that's something we always have to weigh in offering that to a patient. It's like, well, is your lymphedema to the point where transferring lymph node is something that is going to significantly outweigh the risk of developing lymphedema in the donor site? So the donor sites are anywhere you have lymph nodes. You have them in the groin, you have them in the submental area, you have supraclavicular area, you have lymph nodes inside your abdomen. So some microsurgeons are doing lymph node transfers from even inside the abdomen or the omentum. But that does involve a little bit more invasive surgery because you are going into the abdominal cavity, and it usually does require a general surgeon be present. So for lymph node transfers, the least invasive way that we approach this at PRMA is with the conjunction with the flap, because the lymph nodes are right there connected to the flap, and it's easy to take those lymph nodes and transfer them. And in our experience, we have a very low risk of developing lymphedema in the affected leg.
So I guess if somebody isn't going to a flap procedure, or they're just having flap closure, or they're having implants, can the lymphedema surgery be combined at the same time?
Yeah,
or only with a flap?
So great question. So the lymph nodes can only be done at the same time as a flap. For the lymphatic venous anastomosis, we've done it sometimes at the same time as another procedure. It's challenging, and it's not my preferred way, and I'm really trying to avoid doing that because it becomes in the operating room. When I'm doing an LVA, everything has to be very still. They're very small connections. I don't want a lot of patient movements. And if we're trying to combine it with a different type of reconstruction and things, it becomes a little bit of scheduling and just operating room coordination. It just makes it a little bit more challenging. So I like to do it as an isolated procedure. But can it be done? Certainly. There are people who do that. In my hands, I feel like I am more better able to give a better result if I do it as an isolated procedure. We're just focusing on the LVA, focusing on these little tiny connections that are, require lots of concentration. So I don't want to have the distraction of the other things.
Is it in the known area, like to take the lymph nodes? Is it the groin? Is it the stomach? Do you know? Or it just depends on everybody?
I'm sorry, say that again?
So when you do the lymph node removal, you take it from another piece of the body.
Mm-hmm. Uh-huh.
Like, is it groin? Is it clavicle? Where's your most, because I know there's a lot of women on the call tonight who have lymphedema. So I want to make sure that we're touching every aspect of lymphedema.
Yeah, so you can develop lymphedema in your lower extremity from, gynecologic procedures, other procedures that involve, surgery a surgeon would take lymph nodes from the groin area. So even like a melanoma, for example, and somebody's going to get radiation for those types of things. Mm-hmm. Certainly they can develop lymphedema in the lower extremity. Truncal lymphedema is something that's kind of interesting because you can have a disruption in the lymphatic flow in anywhere in your body. And sometimes that presents with truncal lymphedema, and that's a little bit more challenging to approach because we don't have a good way of studying that necessarily. When we do an evaluation for lymphedema in the upper extremity, I can inject the dye that we use to study these patients. We can inject it in the hand. I don't really have a good area to inject in the trunk because it's not a linear structure where we can very easily identify a disruption in flow. It's a little bit more challenging as a clinician to diagnose lymphedema in that area and also to manage it.
And I know as you guys were a very well-known center in the world, around for all of you guys, do you guys recommend, does PRMA recommend preventative lymphedema surgery at the time of reconstruction? So instead of waiting for lymphedema, can we be proactive on it?
Yeah, so this is the part where, the shared decision making really is an important part in taking care of the breast, our patients, and in our case, breast cancer patients. Whenever I have a patient who I know is going to have those risk factors, it's something I have a discussion with them. I say, hey, look, we're going to go in for breast reconstruction. You have these risk factors. I think it's important that we're going to do this reconstruction, but also consider potentially doing a lymph node transfer at that time. You have to know there is a risk with doing that. This isn't, there's not a perfect surgery. There's never any perfect surgery. There's always risks, right? So we always have to discuss those risks with the patients. And if we feel as a clinician, my job is to educate the person. And I say, look, these are the risk factors. This is, and then sometimes it comes down to, well, what do you think, doc? And then, I'll give my best, advice. But I want them to understand, number one, the risks with doing the surgery, but also the risks with not doing the surgery. I want them to know, hey, lymphedema is a real thing. It can happen. Do I feel that your risk is higher in not doing something? Then I would, convey that to the patient. But I really want them to feel like they have been educated and empowered to help make those decisions.
And I think that's what makes you guys so unique at PRMA. I talk to Dr. C and Courtney all the time, and the biggest problem is there's no standard of care, right? How many cases can be avoided, right, with lymphedema? How many more women should know that microsurgeons exist and they need to be seen by microsurgeons, not just a plastic surgeon should be doing a flap? And I just think it's so interesting as technology comes out, why you guys are so different and how you help us educate and empower the community. Because again, like you said, it's about empowering the community and educating them because we don't know our options that we don't know. And there's not a PRMA all over the world, there's just you guys in Texas, and it's so different in different states out of the countries, the standard of care. So it's interesting to know, how these procedures really work. Are they effective? Are we hurting our women? Are we benefiting our women? Where is that piece of education missing on lymphedema? Because I had 2 requests today for lymphedema sleeves for rapid shunting. So it's are these women getting these options out there?
Yeah, and speaking about the sleeves and evaluations and things, for those patients who are going to be at risk, if first of all, thank you for doing this. You're a tremendous resource for patients who, like you said, don't have a PRMA in their neighborhood or in their city or even within their state. And you may be the only resource they have to get good education. So I applaud you and your efforts. That's fantastic.
Thank you.
So for the therapists, if you're a patient and you're going to have those risk factors, hey, I'm going to have lymph nodes removed. Hey, I'm going to get radiation. Ask your general surgeon. Just send me to a lymphedema therapist or send me to a therapist who treats lymphedema patients. Not every city has a certified lymphedema therapist, so that's also a challenge. But many therapists have training with lymphedema, and at the very least, one thing I say, we have patients come from out of state, and they also may not have the resources available to them. One thing I've been recommending to patients is dry brushing. It's something that's inexpensive. You can get a dry brush. It's like a natural bristle brush. You can get it on Amazon. You can find it at different health stores and things like that, like $12, $15. And it's not a replacement for a certified, lymphedema therapist. But with dry brushing, you use this little bristle brush and it gently kind of brushes on the skin and it actually stimulates the lymphatic channels to start working. When I do these LVA procedures, you'd be surprised how minimum pressure is required to move fluid along the lymphatic channel. And it's just incredible. We do these studies. I'm looking at it real time with a dye, and I can see the lymphatic channel, and I'm just very lightly touching the skin, and you see it move. And it's like, wow, that's incredible that it does something. Because our patients that see these lymphedema therapists, one comment they often say is, I didn't expect their touch to be so light and the profound effect it had. And it's just, I think that's the dry brush is something that's very inexpensive and can only help.
I never heard of it, so I'm definitely going to look into it, and I will share with all of you ladies on Instagram later. I'll take a picture of it, but it's interesting because even like lymphatic massages, right? Like not finding somebody who's truly qualified, who's qualified or who knows what they're doing. Yeah, they're painless. People are like, they hurt. I'm like, they don't hurt. They're getting all that fluid out of your body.
Yeah, and the patients will often say, wow, afterwards I had to urinate a lot, and I didn't realize how much fluid was returned back to my systemic circulation. So that's a common comment they have.
Definitely. I have 2 questions that women sent ahead that I'd love to ask you.
Sure.
First, I have a question. Why do women get lymphedema after a mastectomy when they do not have any removed? I have lymphedema in my right breast. It is 2 to 3 times larger than the left, but I did not have lymph nodes removed.
So I missed part of that question. So they do not have, they have lymphedema in their breast and have not had lymph nodes removed. So
correct.
That's a real challenge. It's like truncal lymphedema. And what's happened is, so lymphatic channel, there's no lymphatic channels in muscle. Lymphatic channels, they're like blood vessels. They're kind of like veins. They're very thin little channels, little vessels. They travel underneath the skin and in the subcutaneous fat. When you've had a mastectomy, the surgeon who is removing the breast cancer and removing as much breast tissue as possible, if that tissue becomes very thin with the removal of the breast, it can affect those lymphatic channels. And one common thing that you will see and how that will manifest is you will actually see the skin change overlying that area. And you'll see little dimples in the skin. And we have a medical term for that. It's called a peau d'orange. That's just a fancy way of saying orange peel. I think it's French. It's an orange peel look to it. So if you look at an orange peel, it has those little dimples in it. That's essentially lymphedema within the dermis, and it's causing those changes. So that scenario is challenging to treat. With a flap procedure, that can improve because when we bring the flap up, it does have its own lymphatic channels. And if those lymphatic channels are able to make connections to the overlying skin, it can help with that drainage of fluid. But it is a challenge.
And then I had a lumpectomy last April, and a cluster of 7 benign lymph nodes were removed. It was only supposed to be the sentinel node. Then radiation. Afterwards, I retained fluid in that breast. Physical therapy says that scar tissue blocks the flow. 1 incision scar, now not 2, located at the 1 o'clock breast. Physical therapy, did massage therapy, but it always reoccurs. Are there any other treatment options or just PT for maintenance?
Oh, that's hard to give very specific advice with, without examining and knowing their full history. So I'd hate to, weigh in on and give a very specific advice. I would encourage the person to reach back out to their surgeon to see if there's any other treatment options. It sounds like they may have had a seroma, which is a little fluid collection. And when you have a seroma, a little capsule walls off, and it can keep accumulating if that tissue becomes very encapsulated. So sometimes it does require surgical removal of that tissue. But without examining the patient and knowing their full history, imaging can always help in determining what is going on there, like ultrasounds, MRI, CT scans, those types of things. But there's just so many things that could be going on.
Have you ever heard of lymphedema in your pec muscle?
No.
No. Okay, that's another question. Perfect. So, as we're wrapping up, and I'm seeing if any other questions are here, maybe you can give a couple words of advice to women on like how you educate the community, or even to men or husbands or caregivers that are on the call. Sometimes we see our wives going through this, and like, what can we do to educate them to continue to make a difference in the community? Obviously we're welcome to have you back on to making sure that lymphedema is brought more awareness because knowing before is half the battle, right? If women are aware of it, then it's going to save a lot of surgeries. It's going to save a lot of women, you know, from suffering and going through. Because, I mean, I personally know so many women who suffer for so long and finally just decided, oh, well, I'm going to get fit for a sleeve, and they got the compression and they're doing better. But it's like, what are your other options for those women who don't want to? Like, what's your advice to make sure for our physicians that are listening or women that are listening, again, you know?
Yeah. So, I mean, for the patients, I mean, you're your own biggest advocate. Nobody's going to advocate more for yourself than you. So educate yourself. You know, that's your biggest defense. Listen to lectures, you know, join different groups such as this. For clinicians, you know, if you're learning about this, you need to find out what options are available. And if you don't have the resources to provide, you know, for your patients, you need to point them in the right direction to people who may have those resources available. So those are the, you know, the two ways that I would, you know, for clinicians and for patients. If a patient is being treated by a physician who doesn't know, ask the clinician, ask the question, hey, what do you know about this? Do you know any resources available to me? You know, and start that conversation. And as a clinician, I'm educated by patients all the time. I had a patient who anecdotally had a issue. She believed the medication was causing issues with her lymphedema. So she had done some research, and it was new information to me. So I started researching it. And I have also seen a correlation. I'm not quite sure yet. I'm still doing some research, but anecdotally, she experienced this, and there is some evidence that there may be an affiliation with a certain estrogen receptor blocker in lymphedema. So lymphatic channels have certain estrogen receptors, and they feel that by blocking certain estrogen receptors, it can lead to developing lymphedema. And there's not like great literature on that. It's very preliminary, but there is some affiliation, some loose causation that there may be there. So, but that was new to me. So I'm always trying to learn as well as a clinician.
Let's see. We have one question. What kind of lymphedema concerns for ovarian cancer survivors? I had 15 lymph nodes removed during my debulking surgery.
Oh, so the lower extremity, you know, in those areas, you have to just be careful with the. Be aware of what's going on with the lower extremity swelling. Again,
she's actually BRCA positive too. I guess maybe that's probably why she's asking. She is BRCA positive. She is in remission, cancer-free from ovarian cancer, now BRCA positive, and thinking about doing a prophylactic bilateral mastectomy. So her question is pertaining to that. I'm sure that's what's on her mind.
Okay, yeah. I mean, if you're going the prophylactic mastectomy route, hopefully you're not going to need lymph nodes removed in that scenario. So as far as the you know, risk for lymphedema in the upper extremity, I would say is not significant. But you've already had lymph nodes removed in the groin pelvic area. That's something to be aware of. And maybe for you, evaluation by a lymphedema therapist would be appropriate because you are, you know, at risk.
Okay. Well, thank you so much, Dr. Garza, for coming on and sharing all this information.
Oh, my pleasure.
You know, maybe we'll have you back on in a couple months just to talk more about it. I know last month was National Lymphedema Awareness Month. We did miss it, but it's not something that we forgot about. Obviously, you know, we do need to bring more awareness to it. And if you have papers or you have any evidence and stuff that you want to share with our community, we'd love to see it to, you know, let these women know. I think, again, it's so important, you know, educating yourself, being your own advocate, and, you know, coming to groups like this to support us and, you know, our physicians, and just coming together to make sure that education across the board. And I know personally from my own personal experience and being a founder of a nonprofit organization, there is no gold standard for breast reconstruction, for lymphedema surgery, you know, and if more physicians were aware of the options or shared the options, I think a lot less women would be going through the battles that we go through after surgery and face, you know, revision after revision, or not knowing, you know, or how far the DIEP has come or any of these flaps have come. It's just so imperative to connect with physicians like you all across the world. You know, like you said, people come from out of state to you guys. I know your patient advocates in your offices are amazing. If anybody has insurance questions, you guys are always welcome to reach out to their office. They definitely have one of probably the best offices I've ever dealt with in this history in 5.5 years.
That's awesome. Thank you.
No, you're welcome. I mean, I tell Dr. C all the time, you know, what you guys do is a niche, and that niche needs to now make a gold standard for us women. And anything
I
that we
agree.
can do to continue, you know, and I'm sure maybe you can relate, you know, microsurgeons aren't spoken about enough. You know, you
Hmm.
go see um you go see option Dr. A saying Dr. A says, oh, well, I do implants. Okay, fine. Well, when you're faced with a diagnosis or you find out a genetic mutation, you don't research your options, right? You just say, okay, I want to go with A, but
Hmm.
not realizing B, C, and D have four other options. And I think women need their options up front. You know,
Yeah.
it's traumatic enough to be diagnosed or found out you have a
Hmm.
genetic mutation,
Hmm.
but for our survivors and our metavivors and all these other women that are facing strong battles, why can't we just be given this information up front? Why
Hmm.
does it have to be so difficult and
Hmm.
not share this information? And I'm sure, as you have seen, like in the medical community has definitely changed. I mean, I found out I was BRCA positive in 2004. For
Hmm.
2021, you know, things have definitely changed.
Right.
I mean,
Right.
drastically, but you
Yeah.
know, reconstruction options are still not being spoken about. And it's so
Yeah.
mind boggling to me, as you guys have such a special niche in microsurgery.
Hmm. Hmm.
So I really do appreciate you coming on. And if anybody has any questions, you guys can feel free to DM me and I can reach out to Dr. Garza at the office and get you guys some answers. Obviously, no medical advice is given. And again, thank you so much for coming on and dedicating your time to helping the community learn and educate.
No, of course. Of course. Thank you again so much. It was great.
Perfect. And we look forward to having you back on.
Okay, great. Bye bye.
Take care. Bye bye.